Mrs. Baker. I'm Bailey. I'm going to be your nurse today. We're going to go ahead and check you out and do a head to toe assessment on you. See what's going on with you. First, I'm going to shut the door and wash my hands, and I'm going to start out with my QSIN. So, I'm going to check your wristband, your date of birth. Can you tell me your name and date of birth? Okay. Correct staff names on the whiteboard. You're not on any oxygen. You don't have any feeding tubes. No abdominal tubes or drains. Don't have any chest tubes. Don't have a trach. You do, looks like you might have an IV saline lock because you will be getting your meds later through IV push. So I just want to make sure I check that site, make sure there isn't any tenderness and I don't see any infiltration or it's not hot or no pain. We don't have anything currently hooked up. Side rails, 2 side rails, beds in low position, call lights in reach, no obstacles at the bed. Patient's assistive devices are to the side, water and pitcher cup. Don't have a urinal, your toilet is to sides empty, and trash bag is attached. Alright. So before I begin my head to toe assessment, some of the signs and symptoms I might see with a patient with a peptic ulcer is upper abdominal pain, heartburn, indigestion, nausea, passing gas, vomiting, fatigue, abdominal discomfort, and bleeding. And some of the assessments that I'm going to want to make throughout my head to toe is their history. So if they have any risk factors, drugs, GI upset, relationship to eating and sleep, actions that are taken to relieve the pain, assess for dyspepsia, assess their GI, gastrointestinal area, assess for vomiting, pain, constipation, diarrhea, hypovolemia, and signs of infection or inflammation. All right. So can you tell me where you're at today? Can you tell me the day or month or year? Okay, I'm going to look at your face, check for symmetry. Everything looks good. Right. I'm going to check your pulses bilaterally. I'm going to go ahead and feel for your skin, feel the temperature of it, and feel if it's dry or wet. Take your blood pressure and look the respirations. Okay. And then I'm going to go ahead and I'm going to listen to your lung sounds. Okay. If you lean forward for me. Okay, and then can you lift up your left arm? And your right. Okay, I'm going to go ahead and listen at your heart. Okay. Are you having any kind of pain or tingling up in your arms or anything on your upper extremities? Okay. Let me see your hands. Can you pull away from me, push towards me, squeeze my hands, wiggle your fingers. Okay, I'm going to check your cap refill bilaterally. Right, and your skin turgor. And then, are you having any abdominal discomfort today or any kind of pain? Right, and I'm going to go ahead and lift up your shirt. I'm going to look, see what we got going on. Right, I'm going to go ahead and listen to those bowel sounds. Okay, and I'm just going to feel around to let me know if there's any areas that are tender. All right. Have you been passing gas? Can you tell me when your last bowel movement was? Okay. Okay. And are you having any problems going to the bathroom at all? Any burning or any abnormal discharge that you've noticed? Okay, I'm going to check out your legs here. Right, and then I'm going to have you push towards me, pull away from me. Okay, wiggle your feet. I'm going to check capillary refill bilaterally on your feet, and I'm going to check your pedal pulses. Alrighty, so what I found, your vital signs, your temperature was at 99.2, your pulse was at 85, your respirations were at 17, blood pressure was 130/72, and your pulse ox was at 97%. You stated that you had epigastric pain, you've had it for 3 days. Your lung sound sounded clear, your heart sound sounded clear, or heard the S1, S2 sounds, and there were no murmurs. Your GI did state that you were feeling nauseous. Your bowel sounds did sound a little hyperactive. You stated you had some tenderness in that right upper quadrant of your abdomen, but there was no tenderness in the right lower quadrant, left lower, or left upper quadrant. And my patient also, when I was done with my assessment, my patient did vomit. She vomited 300 milliliters, and it was coffee ground emesis. And just I'm going to educate you a little bit, Mrs. Baker. Things that for the future you should know to avoid is just any caffeine, alcohol, smoking, spices, or coffee. You want to make sure you're eating small, frequent meals. Make sure it's a bland diet, and you want to make sure you're decreasing your stress. Alright, so I'm doing my IV push medication administration separate from my initial video. But so basically, right now my patient's just thrown up 300 milliliters of vomit, and it was coffee ground emesis. So I was just ordered to give 4 milligrams of Zofran IV push by my doctor. So before I'm gonna walk in, I'm gonna say, "Hi, Mrs. Baker. I'm Bailey. I'm gonna be your nurse, and we're gonna go ahead and give you that 4 milligrams of Zofran. And what that's gonna do is that's for your vomiting, to help stop that, so that way you aren't doing that anymore. It'll work right away. Its peak will be about 15 to 30 minutes, and it's going to last for 4 to 8 hours. And you want to make sure you're to notify the doctor or one of the nurses if you're having an irregular heartbeat, you're having serotonin syndrome, or involuntary movement of the eyes, face, or limbs. So before I give this medication is given undiluted, and it's given over 30 seconds, but it's preferably 2 to 5 minutes, so we're going to go ahead and give it over 2 to 5 minutes. I don't have my primary IV bag, so I'm just using my IV piggyback and my secondary tubing, because I don't have primary secondary tubing either. And then also some common side effects that you might have, Mrs. Baker, is you might have headache, constipation, or diarrhea. And some of the life-threatening ones that you might want to just look out for is if you're having any serotonin syndrome, Stevens-Johnson syndrome, toxic epidermal necrolysis. Okay, so I'm going to go ahead. I'm going to wash my hands and close the door. Put on some gloves. So I'm gonna go ahead, I'm gonna check my doctor's orders again, see what I'm being administered, make sure I've got the right medication. So Zofran I need 4 milligrams. Okay, I've got my Zofran. Make sure I wipe off the top of my medication container. Gonna put the amount of air that I need into my medication. And withdraw the amount that I need. Okay. Make sure you're gonna lose the air bubbles out. Okay. Alrighty. So I'm just gonna go ahead and I'm gonna recap it. Oops. And I'm gonna put it in through here. And just to make sure, before I would give it to or administer the medication, I just want to make sure that I'm going to look at the IV site too to make sure that it's not infiltrated or I don't see any inflammation or anything like that. So I'd wipe off the top, make sure this is sterile, and I'm going to flush before I give the medication. So I'm going to also wipe down this just to make sure it's extra sterile, and I'm just going to give 2 milliliters. That I would flush, and then I'm going to wipe off. I'm going to recap my saline. There, it's not getting dirty. Wipe it off again, and I'm going to go ahead and administer my medication, and I'm going to administer over 2 to 5 minutes. So I can't actually put it in there. So I'm just going to, I'm just going to say we administered over 2 to 5 minutes, and then wipe off the top again, and I'm going to flush again, and flush it, wipe off the top again, and then I'm going to put on my cap. Oops. Okay, so then I'm just going to remind Mrs. Baker, so you should be feeling better instantly. If you do become nauseous again before that 4 to 8 hours, you can let me know. But just know that it will wear off within those 4 to 8 hours. That's how long it usually lasts. And if you're having any of those side effects, just let me or your doctor know. Alright, so now I am reporting off to my nurse. I had Mrs. Baker come in. She's a 54-year-old female. She came in complaining of nausea, severe epigastric pain for 3 days. She's taken ibuprofen for 100 milligrams 3 to 4 times a day because she also has osteoarthritis. So then did further assessment. Patient demonstrated pain and tenderness in her epigastric, she guarded her epigastric region, but there was no tenderness to palpation over the right-left quadrant, left lower, left upper, but there was some tenderness in the right upper quadrant. Vowel sounds were hyperactive, her lung sounds were clear, S1, S2 sounds heard, no murmurs. But then after it was done, she vomited 300 milliliters of coffee ground emesis. Then notified the doctor, and we administered 4 milligrams IV of Zofran every 6 hours. And I gave her some oral care. So then she came back. She was weak and drowsy. Fecal occult test was positive. Her CBC showed hemoglobin of 10, hematocrit of 31%. Told to insert an NG tube to evaluate stomach contents and decompress the stomach. And then we connected the NG tube to intermittent low suction. Let her, then her blood pressure dropped 96/60, and in the suction canister was halfway full with blood. Then she was pale, diaphoretic, and drowsy. Heart rate went up to 122. Notified the provider and gave her 2 units of PR packed red blood cells. Called the gastroenterology for an EGD, and then 30 minutes later, she's taken to the GI lab for EGD. They found 2 slow bleeding gastric ulcers, and they cauterized that, and then they found 1 arterial bleed, and they repaired. And then she returned to the unit for post-procedure for observation.